Okay, so I'm Annie, and Karl will be joining us through the workshop, and you'll get to meet both of us during the session. We acknowledge the traditional custodians of the land on which we're meeting and pay our respects to elders past, present, and emerging here in Australia, and to any Aboriginal or Torres Strait Islander professionals attending this workshop. Um, I mentioned at the beginning, but some of you may have missed this, that it's great if you can put your name and your city or country in the screen. You can do that by hovering over your screen image, and you'll see there's a little box with some white dots in it, a little blue box with white dots up the top right of your screen where you can see yourself, and that will allow you to rename yourself. Or you can go down to the participants section and find your name, and then you can rename yourself there. If you can't work it out, don't worry, it's not a big deal. So I think that's the main things. Closed captions, again, I'll remind you, if you want to use closed captions, it's in your toolbar at the bottom of the top, probably under the section More, and you can turn the closed captions on and see them on the screen at the bottom. One other thing, we are recording, as you probably know, and if you miss some of the sections or you want to revise some of the sections, you can email me and ask for a link to the recording, which will be available for a week or two. Okay, so the three sections, as you probably know, when you looked at the background to the workshop, we've got the first session is about analysis. So what you see when you watch somebody reaching, grasping, or attempting to move their arm, how to recognize compensations, and how to use slow motion video to help you with the analysis at work and also with the stroke survivor themselves. Then next session in 2 weeks' time, we'll be giving you some homework in between to go away and do and apply some of the information. And then we'll come back and spend a lot of time thinking about ways to get muscles to contract in the shoulder, in the forearm, in the hand, and using different interventions, mental practice, mirror therapy, electrical stim, to get muscles to contract. Talk a bit about some of the guideline recommendations here in Australia, and they're very similar in the UK and Ireland as well. The final session, we're looking at much more advanced hand coordination, the area where I think a lot of therapists often think people are managing quite well or well enough, and don't really continue to train things like handwriting or cutlery use until the person's got sufficient skill to be able to do these tasks in a number of different contexts. So we'll spend some time thinking about ways to apply mental practice, mirror therapy, and constraint therapy, and to a lesser extent, electrical stim for muscles that are still not contracting well. Now, I asked you in the emails that hopefully all of you received to think about what you particularly want to learn. You know what the content or curriculum is, but some of you may have particular topics that you want to make sure you learn about and get more information and more skill in. So I'm going to do a little poll now to ask you to comment on that. So you will need a mobile phone or a cell phone or a device of some sort that you can scan this code, or you can go into a web page and put in menti.com and then put the particular code in that you can see on the screen. And that will take you to a quiz that I'm just going to start. The first question will be about what you want to learn, and you can type in a few words and 3 topics, and we'll see them coming up on the screen. Then it will go straight into an anatomy quiz. And don't worry if you don't know the answers. Part of the reason for doing the quiz is to get you to think about what you know and what you remember. You can, of course, use your cheat sheets in your manual if you want to. So I'm going to stop sharing and bring up the Menti screen. Where are we here? Menti, where's it gone? It's disappeared. It has gone. Here we are. Google, there we are. Now let's see if I can bring that up. Can you see that on the screen, Karl? Is that visible, Karl? Is that visible? I've just got enhanced encryption. Can you see that on the screen, folks? Just nod if you can. Okay. So I'm just going to move into the first question, and you should be able to type in there. If you haven't managed to join, just go into an internet screen or a web screen with Google or Safari and type in menti.com. And once you get to that platform, type in that number at the top of the screen. So I can see some of you are managing to do that successfully. You'll only be able to put in a few words, not long sentences. I don't. So for anybody who's just arrived, it might be easier if you just pass this section, but we're going to be doing an anatomy quiz shortly using a little platform called menti.com. So you can go onto an internet like Safari or Chrome, find menti.com, and then put the code at the top of your screen into menti.com. So just a couple more people to respond. Not surprisingly, movement analysis comes up, which is the focus of the next 3 hours. But we've got people wanting to know about best practices from the guidelines. And I'll bring the screen up when we start the next session as well. Okay, I'm going on to the next series of questions. We've got 6 quiz questions about anatomy, and you'll hear a little bit of music in the background. If it's annoying, you can just turn the volume down. And just do your best to answer these questions. Okay, here we go. Answer as quickly as you can to get more points. Last second. Okay, so the muscle that's not responsible for external rotation is pectoralis major. So you'll see if you're quick at answering, you get more points. Next question. 1 second to go. And the answer is anterior deltoid is not responsible for protracting. Okay, well done, Alex and Grace. Up there. Oh no, it's changing. Right, which muscles abduct the fingers? Wait till a few more people answer. And the correct answer is the dorsal interossei, the muscles on the back of the hand, and abductor digiti minimi. Next question. Ten seconds to go. 7 seconds to go. Okay, and the muscles that adduct the arm, adduct the fingers, are in fact correctly the palmar interossei muscle. Okay, let's see who's been the fastest and the correctest. What's correct? Alex and Elise. Very good. Right, we've got 2 more to go. What is the role of the lumbricals? A couple more people still to answer. Well done. So the answer is flexion at the MCP joints and extension at the PIP and DRP joints. 1 more question to go, which is about the thumb muscles. So well done, Alex. You're looking very good there. Last question, which muscles abduct the thumb? And most people have got that correct. The 2 abductor pollicis muscles, longus and brevis. Okay. Well done, everybody. I'll just stop sharing and go back to the slides. If you have any questions at any point or are having any difficulties, you can use the chat at the bottom of your screen and type in any questions or comments that you might have. And we'll ask you to do that at different points as we go along. Just so you know, we have a range of people from different countries. We have, I think, 11 people from England, somebody from Guernsey, a couple of people in Dublin, somebody in Belfast, Singapore, 4 Kiwis, and hopefully Luciana from Brazil. Hi. Lucy, is it Lucy or Luciana? If you want to unmute and just say hi. And I wanted to make sure too, Luciana, that you know how to get the closed captions to work on your screen. Just nod if you can. Have you been able to get the closed captions to work? Do you want to unmute I can unmute you. Maybe. No, I can't. If you want to unmute yourself, hover over your screen, Luciana, and you'll see there's a little red um, microphone. If you click on that, that will unmute you so you can talk to me. I might get Karl to type in the chat to you and see if he can help you while we continue on. Um,
Sorry, it's not Luciano, it's Jane from Guernsey, but I missed the bit about the closed captions. I don't know what that is and what we need to do. Sorry.
okay. So if you want to be able to see, a bit like when you're watching television or a movie, if you want to be able to read what's being said at the same time as I'm talking, that's what the closed captions are for. So it will transcribe live on the screen what's being said. And we've put that on so that people can choose whatever language they would like if they want to do that. So to be able to do that, you go down to the bottom of the screen where it says more, and you should be able to have an option there to put closed captions on. It will be beside the buttons for breakout rooms and transcript and meeting information and settings.
All right, thank you.
And most of you will probably want English if you want it, but for Lucy, the Portuguese Brazilian is the option for you. So we've made that possible for you.
Thank you.
Okay, so if everybody wants to go on mute again, and if you have any questions and you're having trouble, then put a message in the chat, and I can see that Luciana has done that. Um, so I'll get Karl to communicate with you while I'm talking.
Luciano?
Yeah. Okay, screen share again. Right, so learning objectives, as you remember, we've got focus on the essential components, what we should typically expect to see when somebody reaches forwards and transports their arm to a glass or for cutlery. Common compensations that you see when people are attempting to do that when they're very weak. What we can do during the initial assessment and during training sessions to minimize those compensatory strategies so that people are not practicing the compensations every time that they reach. So things like bringing the object as close as possible to the person, perhaps putting it on a tray table on their lap or on their knee, rather than getting them to lift their arm up onto the table, which can be very difficult. Obviously, you'll be able to plan and conduct an assessment and training session using some of these principles and task-specific practice. And all the way through the workshops, we'll have references that support the use of these evidence-based treatments and interventions. So at the very back of your notes, you'll see there is a reference list that you can go to at any point. Hopefully every reference that we're using is in the manual. Okay, take-home messages. We'll have take-home messages for every section and every the three different workshops. So first, for the whole workshop, we want to be able to model systematic goal-directed analysis and training when we're working with stroke participants. So we want to be systematic, have goals. So when we're asking somebody to reach for a glass, reach for a cup, reach for a fork or a knife, give them an object to reach for, ask them to put the cup in their hand and ask them to move the cup from A to B. So give them a goal, not just can you lift your arm? So give them something to touch, something to move. We want you to think like a movement science, hypothesize. What do you think the cause of the person's movement problems are? Is the problem at the shoulder or the hand or both? Is the thumb the problem? Is it the fact that they can't extend their fingers? And then target those causes with some training. And if you're right, then that should make a difference. If you're wrong, then you can go on and then start to look for other possible causes. And quite often there are multiple areas of problem. And that means that you need to test and retest, measure and remeasure, and count repetitions and provide feedback to people to help them to improve their performance. And the evidence-based interventions that we're going to be looking at target particular muscles and particular tasks. So electrical stimulation, for example, targets individual muscles with high repetitions. Um, and by doing evidence-based interventions and trying to get the repetitions up, the magic number is 300 repetitions in a treatment session or in an hour. And I'll talk more about that as we go through. That makes us to be more accountable for what we're doing in our sessions. So we're not just trying a bit of this and a bit of that and being eclectic. We're being very focused and evidence-based and accountable for the quite limited time that most of you will have face to face with people. And also, we should expect that people will change with the evidence-based interventions that you're using. Within the session, you should expect to see measurable change, and between sessions, you should be expecting to see measurable change, even for people who are months or longer after their stroke. There are, of course, some people who do not change and do not get muscle recovery, but they're a very small proportion of the people that you see. Maybe 10% of stroke survivors don't get motor recovery. And we don't know in the first couple of weeks who they are. We do have some algorithms um, that suggest we might be able to identify those people who are not going to get motor recovery, but that's not really quite accurate and specific enough yet, and it's not in our guidelines as a strategy to use the PrEP and the safe um, strategies for identifying people who may not have motor recovery. So there are the three key take-home messages. Now, a little quiz for you before we start the content. Just do the best you can, and we'll come back to the answers for these at the end of today. What are four essential components of reaching to grasp for a cup? Two at the shoulder and two at the hand. And the pre-reading may have helped you with this. Question two, why is thumb abduction important for hand function? And if you can, name essential components of knife or fork use when a person's cutting food. Two common compensations at the shoulder when somebody's reaching for a cup. So what might you see somebody doing when they're weak and can't take their arms straight forwards? If somebody can't abduct their thumb when they're reaching for a cup, for example, how might that affect their ability to take their arm forwards and to open their hand, to transport their arm and pre-shape their hand? What might it look like? Thinking about knife and fork, what are two common missing essential components in the hand that can affect the use of a knife and a fork? It might make it difficult to hold a fork or to cut with a fork and a knife together. And see if you can describe one strategy, one method that you could use to sort out whether somebody's got a problem at the shoulder or the hand when they're reaching. Again, if you've got no idea whatsoever, that's okay. That's why you're here. So as I said, we'll come back to this at the end. Little bit of anatomy revision to bring us all to the same starting point. And you have these images in your slides. So the muscles that transport your arm forwards or your hand forwards for a cup, anterior deltoid, the big muscle at the front of your shoulder, the clavicular head of pectoralis major, and biceps brachii and coracle brachialis. So they help to transport the arm forwards towards the cup, if the cup's directly in front. Protraction, so this movement here that you can see me doing, this is protraction, where my scapula is moving forwards. And if you put your hand around the back of your shoulder, you'll be able to feel your scapula moving. The muscles responsible for that movement is anterior on the front of the chest wall and pectoralis major. And this is often where we'll start if somebody is very weak, can't lift their arm up off their lap, can't slide their hand forwards on their knee. We may start putting them in a position to see if their protractors, these muscles here, can start to get a contraction actively. Internal rotation is not a movement that you often have to train. I can't think of anybody I've had to train, but the muscles involved in internal rotation, so rotating the humerus inwards, pectoralis major and latissimus dorsi, two muscles, subscapularis, teres minor. So we've got four muscles there, two very big ones. And external rotation, which is this movement here, where the humerus is rotating outwards, coming from this position, reaching forwards. We have, again, four muscles, but they're smaller muscles. A lot of people that we'll see in rehabilitation have weakness in the external rotator muscles and can't move their arm from here to here without compensating. So we're talking about external rotation quite a bit. I won't go through individual flexor and extensor muscles of the forearm and the hand, but we will come to talk more about them next time that we meet. And we'll spend a lot more time on the intrinsic muscles of the hand in the final week when we're looking at training cutlery, hair care, handwriting. So we have superficial muscles and we also have deep muscles. And when we use electrical stimulation on the back of the forearm and the wrist, it doesn't discriminate between the superficial and the deep muscles. And in fact, if we're trying to get the extensors to contract, very often the electrical stimulation will get the flexors as well in people who've got quite skinny arms. The small muscles of the hand that we'll target with mirror therapy, mental practice, electrical stim, and task-specific training, you can see here. And it's helpful to show people where these muscles are um, when they're trying to get messages from their brain down to the muscles. The quiz questions, one of them was about interossei, palmar and dorsal interossei, so we'll have a look at them in a minute. Uh, Here's the abductor pollicis brevis and longus, which is what we often target with electrical stimulation. And when we're talking in a minute about conjunct rotation, so being able to make this cupped shape that you need to be able to pick up cutlery and also to be able to hold a glass, you need to be able to bring the fingers in like this. It's the long finger flexors and the small muscles of the hand, the lumbricals and the interossei muscles that help to bring you into flexion and also that rounded cupping shape. So here you are, there's the lumbricals on the left, the dorsal interossei, which separate the fingers, abduct the fingers, and then the palmar interossei that will bring the fingers together. When you use your mobile phone or your cell phone, you're using a combination of thumb flexion, that rotation at the base of the thumb to bring the thumb around so that the tip of the thumb is on the screen. And you use opposition as well. You're opposing the thumb as well as flexing it. The thumbnail changes position as it rotates around, which is a bit of a clue and in your handout, your pre-reading, you had one of these sheets, and we also have, I think, put it at the back of your notes. So here we've been looking at the hand and the thumb muscles, and we'll look at the muscles of the shoulder and the elbow later on. So I'll just pause for a minute to see if there are any questions. You can either write in the chat or if you want, you can unmute yourself. And then we'll go on to look at reaching for a glass. So going back over part of what you were doing for your homework and in the pre-reading. I also didn't mention at the beginning, but we will have 2 breaks. So probably in about 20 minutes, we'll have a short 10-minute break. And then as we get towards 8 o'clock Eastern Australia time, sorry, 8:30, 8:40, we'll have another break for about 20 minutes so that you have time to have a bit of fun out.
Tá. Aí agora você.
Okay, now thinking about reaching for a glass, we want to be systematic and goal focused when we're getting somebody to start in an assessment to reach for an object. In this case, I often have a plastic cup that I'll carry around and use with people. But you may have paper cups, plastic cups, and so forth. So you want the person to reach for something or to, if they have no hand function, we may get the person to put the cup in their hand and see if they can move it from one point to another. Try to find ways to do your assessment where you're not moving the person's hand and arm around. We'll get some practice using slow motion video to help with the analysis so you can watch the person again and again and again without asking them to try and do the movement. This session today will help you to understand what movements, what muscles are involved in transporting the hand and pre-shaping. Karl will talk more about this, but a key message is that the hand drives the shoulder. And what that means is when we move our hand to pick up a cup, to adjust our earring, to pick up a fork or a knife, we move because we've got something we want to do with our hand. So we don't just move our shoulder for no reason. We're intentional. We have an intention with our hand. So the hand is really the priority. We can look for cues to give us an idea about whether the person's rotating their thumb around, and I'll go through these in a bit more detail. We can learn different ways to test our movement hypothesis and describe at case conference, at meetings, and in our medical records, movement problems at a level that other people can understand and that you can intervene at. So in the pre-reading, we talked about different sort of stages or phases, if you like, of reaching to pick up a glass or a cup. So when you reach, you transport your hand forwards, and you can physically see the arm and the hand moving towards the object. You'll generally move quite fast initially, and then you'll slow down. Your hand will slow down as you get closer. And the more delicate or difficult the object is to pick up, the more you'll decelerate, the longer that period of deceleration, because you have to take time and care getting your hand around the glass of red wine or the cup of water. Pre-shaping is what you see changing at the hand, so the thumb position, the finger positions, and the forearm position. We anticipate the size and the shape from the second that we begin to start moving and intend and plan to pick up the glass. Grasp is the point where you physically make contact with the glass or the cup. And this is where you need to be able to control the amount of pressure on the sides of the glass or the cup. Often therapists will talk about people having spasticity when they can't pick up a glass or a cup and they're pressing too hard. But more often it's likely to be problems with controlling the interossei muscles, the palmar interossei, as the person's controlling the pressure. They may only be using the long finger flexors and not have good control of the small muscles of their hand. And there's ways that we can test that. Once the person has the glass or the cup in their hand, they do need to make some small adjustments to control the position. And we'll talk more about that. It's more relevant when we're talking about cutlery, but if I'm holding onto a cup here, I may have to adjust the position of my fingers, particularly if the glass is slippery. You had a worksheet for your homework in your pre-reading booklet, and you'll have another one at the back of your manual that you can use now if you haven't already done this. But if you have completed the worksheet, have a look at that now. And you've got 3 sections to write in for picking up a glass. And we're looking at the essential components list and putting some of those components across into the transport, pre-shaping, and grasp rows of this worksheet. And you can refer to the muscle list or the actions list that you have in your pre-reading booklet as well. So this is a video, a slow motion video, reaching for a glass. And what I'm going to do is just talk you through what I'm seeing as the reaching is happening. And I'm also going to stop the video at various points along the way. And I'm going to use the cursor at the bottom of the screen. You'll probably be able to see this. So I can actually put the cursor on the top of the slider and move it along and stop and go backwards and forwards. So just at the beginning of this video here, I can see that Karl is starting to go from internal rotation to external rotation. So we can see his forearm moving from internal rotation and it goes straight forwards. The elbow crease starts to change from being facing inwards, and the elbow crease changes to facing more up towards the ceiling. Also, what you're seeing here, as well as this external rotation, is forward flexion. So if I go back again, Karl's elbow is starting to move forwards and his humerus is moving away from the side of his body. So we can see forward flexion and external rotation of the shoulder. There'll be a little bit of protraction at the shoulder too because of the distance. There's not much elevation, there's not much abduction, mainly forward flexion of the shoulder, external rotation, protraction, and elbow flexion. Now moving down to the hand, I'm thinking about pre-shaping. What is happening at the forearm and the hand? So you can see the wrist starts to change from being flexed to being extended. The MCP joints start to flex, the knuckle joints start to flex, and the fingers flex as well. The forearm's in pronation, and now it moves into sort of mid-prone supine position with wrist extension, and you can see a big change in the thumb here. The thumb is opening wide into abduction and opposition. And at this point, just before the physical contact with the glass, you can see wrist extension, extension at the MCP joints, some extension at the fingers, IP and PIP joints, and the thumb in a very wide abduction. The thumbnail is not visible. It's around on the side of the glass, on the opposite side here. So they're the main components of transport and pre-shaping. And you can see them if you have a static photograph as well. So in that right-hand top photograph, you can see the humerus starting to move forwards from the back of the chair, and the pointy part of the elbow, the olecranon, is also a good area to look at, a landmark to look at. You should start to see that moving forwards away from the back of the chair. In the bottom two photographs, you can see external rotation. So you can see the humerus is starting to rotate and the elbow crease is starting to move. So it's facing up towards the ceiling. There'll be some protraction because of the distance forwards. There's elbow flexion moving into extension. And looking down at the hand, we've got extension of the wrist, a change from the start position into some supination, and also into a change of ulnar and radial deviation. The thumb is rotating, and so it's the base of the thumb you start to see the rotation, and that changes the position of the pad of the thumb, moves so that it's facing inwards towards the cup or the glass. The thumb moves away from the hand, so it's abducting. The fingers extend, and there's a little bit of abduction of the fingers as well. The other change that you'll see is that rounding shape of the fingers, so that the fingers make contact with the cup and they're opposing the thumb. So we refer to that as conjunct rotation, and that's a combination of the long finger flexors and the palmar interossei, bringing the fingertips into that cupped or rounded position. That's just a description there of the grasp. So closing around the cup. So we've got to maintain that rounded cup shape and maintain some flexion. We have to be able to control the radial deviation so that the cup or the glass doesn't tip. So we have to maintain that position. So, summary, where the glass is placed and what you ask them to do will affect people's ability to reach. So don't put it too far away. Bring it close to the person if you know that they have difficulty with the transport part. So what I will often do is, if you can hopefully see my screen here, I'll just pin it for you. There we are. So rather than put it on the table here, what I might do is put it on the person's knee and ask them to see if they can touch the cup. And if they can manage to do that, then I might ask them to put the cup in their hand and see if they can touch my hand like that. So that will take away the transport component, trying to get it up onto the table, to reach, to grasp. And then we can just have a look. Do they have a little bit of movement at the front of their shoulder? Can they slide rather than having to lift against gravity? So during your assessment, give people a goal, but think about how difficult you're making it for them, and can you make it a little bit easier? Cues to look for, is the elbow crease rotating upwards as the person reaches, or is it staying internally rotated? Maybe they have difficulty with external rotation. Is the radial styloid pointing upwards, or is it facing inwards? And that can give you a clue about whether the person's able to supinate and pronate well. Is the thumb opposite the middle and index finger? So you would expect to see the thumb opposite the middle and index finger, not up at the top of the cup. So we would expect to see it opposing directly across. You would also expect to see the thumbnail on the side here, rather than it facing up towards the ceiling during pre-shaping as the person moves forwards. And you would also expect to see the knuckles in an upright position and not pronated like that when the person's reaching. If a person is pronated, it might mean that they have problems with their thumb coming around, or they may have difficulty at the shoulder. So there are cues that you can look for during that initial assessment. And the advantage of a video is that you can take a video and then watch it a few times with the person. You can take it, if you're worried about how to take the video and store it, you can take the video on their phone or their tablet or device and watch it together repeatedly with them. Or you can take it on your own departmental device and then have a look at it in your own time. So any questions up to that point? That's a revision of what you would have read about in the pre-reading. And I'm sorry, Luciana, we don't have the pre-reading book chapter in Portuguese. We have it in Spanish and we have it in Chinese and Turkish, but not in Portuguese. And I'm glad you've got the closed captions working. Okay, we don't have any questions at that point. Karl, do you want to, we'll have a break and then for 5 minutes, 10 minutes? Yeah, let's have a 5-minute break and we'll come back. It'll be just before 7 o'clock in Eastern Australia. And we'll come back then and look at the missing components and compensations. And if you have any questions, put your questions in the chat.
And now we can move on to the next application of that information that Annie's been talking about. and see how we apply that to people that have movement problems. So the plan with this section of the conversation is around how do we organise our thoughts using the information that Annie's presented about having a systematic way of looking at the arm in terms of transport, pre-shaping, and then grasp and manipulation, and then really trying to use that framework to help analyse where movements are breaking down. One of the things to think about in terms of these essential components is that if any one of them is missing, the way that somebody will reach will be different from what we would normally expect to see. So it's those essential elements upon which the activity actually depends. And so there are commonalities in the way that we reach forwards or out to the side, the essential components of those tasks. And we need to keep that in mind when we're analysing somebody who has difficulties. So when you're looking at normal movement, which is what Annie has been describing, we're describing the common features that each of us has when we reach for a glass, for example, depending on how high it is and all of those other variabilities. But there are certain features that we see in terms of reaching forward. So there's forward flexion, external rotation, elbow flexion, elbow extension, orientation of the forearm for pre-shaping, and then the shape of the hand, wrist extension, thumb abduction, MCP extension with IP flexion to be able to pick up the glass, and then the closure of the hand. And each of us will have very similar ways of doing that. So what we've just been describing is the kinematic features. That is the movement of the limb in space, the range of motion that we see, the extension, flexion, the movement of each of those joints to form the shape that we need to be able to pick up a glass. And that's the kinematics. But what we're also keeping in mind is that the things that we can't directly see, but we make inferences about, and that is the muscle forces that cause what we see. So it's those forces of rotation at the shoulder, at the elbow, at the forearm, at the wrist, at the thumb, at the fingers, at the IP joint of the fingers, and how those muscles work, whether they're working concentrically or eccentrically, depending upon the context of the task. We need to keep that in mind as well when we're analysing. And on top of that, we also have the constraints that are imposed upon us by the environment that we're reaching in. So, for example, where I'm sitting at the moment, there's a table that's relatively high. So I need to get my hand above the table before I can start to reach forwards. So that'll require more elbow flexion to be able to get my hand above the edge of the table to then be able to reach. And so the environment also plays a very strong part in how determinants of what the essential components are. Annie mentioned earlier something that I think for me was a really important insight into upper limb function, and that the real estate that our brains allocate to our arms or the various parts of our body are represented in this little homunculus here. And this looks at the amount of the area within the brain that is devoted to these parts of our body. So you can see here, we have very large hands, and it's these hands that we can use to manipulate and play musical instruments and do all sorts of wonderful things. We also have very large feet, and that has a role to play in being able to keep our bodies upright on a very small base of support. So our brains need to allocate a large amount of resource to our feet so that we know where we are relative and keep our bodies over our feet. And we also have a very large face and tongue because we communicate. It's a very important part of who we are as a species, and we don't want to put nasty things in our mouths. And so this is where the allocation of our resources are. But when I graduated as an undergraduate and then going on to work as a physio, the assumption was that we always needed to work on the shoulder first, and that somehow miraculously the hand might work later on. What this insight has helped me do is to understand that we move our shoulders in various directions because we want to put our hand somewhere. If you think of all of the things that you've done today with your hands, it's been your shoulder has moved because you want to put your hand somewhere. From the first part of the day when you take your blankets off your body and you get out of bed and you go and reach for whatever you're going to reach for, and you go and get the milk out of the fridge for your cup of tea, or reach for the kettle, whatever it might be. Get your car keys to go out to the car, or get your bicycle out of the shed, whatever it might be. Your shoulders move because you want to put your hand somewhere. And this is a really important feature to have and keep in your minds when you're analyzing somebody's movement, in that the position of the hand and how that person needs to position their hand will determine what their shoulder does. So it's a very important insight and important background information to have, in that the hand drives the shoulder and it's not the other way around. Our shoulders don't drive our hands to get them somewhere. It's what we intend to do with our hands that determines what our shoulders do. So when we're watching somebody attempt to do a task, we then need to bring this information about the normal elements, the essential components that people need to do to reach, and use that information to analyze where somebody's movement is falling down. So in this example, this person has been asked to reach for a cup, and they're trying very hard. And we can see that there are certain things and certain muscles that this woman is able to turn on, and there are certain muscles that she doesn't seem to be able to turn on. But we don't know that from the photograph. But what we need to start thinking about is, what is she doing? What is she lacking to be able to reach forwards? And then what muscles is she using preferentially? Because sometimes when people are trying to do something that's very difficult, they will turn on particular muscles that they can turn on, preferentially perhaps to the muscles that they don't have access to. So in this case, this woman does have some elbow flexion. Now, the flexion may also help contribute to the sort of apparent supination of her forearm. She may have a little bit of wrist extension, although that may be gravity helping her. But she seems to have great difficulties making the pre-shaping shape that she needs at her hand. But she does have some muscle activity from this photograph that we can start to explore, and then start to explore the muscle activity she doesn't have in her hand and her wrist, and then start to think about what this woman most importantly needs to practice. So compensations, and we can see this woman also has a compensation that she elevates her shoulder, and perhaps this is a compensation because she can't forward flex at the shoulder. She does appear to have a little bit of external rotation because her hand isn't across her body as she tries to reach. So she may have some shoulder muscle activity, but not sufficient to be able to reach forwards. The problem with compensations is that if somebody practices something over and over again, that's what they get good at. So she'll get good at elevating her shoulder in the absence of having enough forward flexion and external rotation to be able to move her arm forwards. That's what her brain is practicing. So the challenge for us is to find ways to explore what muscle activity she does have, and then find ways for her to be able to generate force in those muscles, preferentially to shoulder elevation in this case. So avoiding early on when you're training people, if you're working in a hospital, for example, and you're working in the acute phase for stroke survivors, It's important to keep those essential muscles and those essential movements in mind when you're training somebody. So you're trying to seek muscle activity that involves forward flexion, external rotation, elbow flexion extension, wrist extension, thumb abduction. Each one of those muscle activity actions is essential to be able to reach effectively. And our job is to try to find a way that people can begin to learn how to do that again. So this involves us thinking like a scientist. We need to think about, why is it that this woman is reaching this way? What do I think the main problem is, and how might I go about assessing her problems? So we need to observe, first of all, and I think it's very, very helpful, as Annie's been suggesting, to videotape somebody reaching, because then you can start to break the information down and look at the kinematics, certainly, to see where the compensations are occurring and what might be missing from the person's abilities to reach for their arm. Importantly, it's essential to give somebody something to do. That's the way our bodies work. It's the way our brains work. So even if somebody has minimal muscle activity, put something in front of them for them to reach for. So there's some endpoint goal that their hand is trying to get to. So it could be a cup, it could be a knife and fork, it could be a tissue box that's next to them at their table, whatever it might be, something to reach for, in preference to just doing a straight manual muscle test. Manual muscle tests do not give you information about what the person can do. They don't give you information about the contextual relationship between the coordination of muscles. They just give you raw data about whether a muscle works or not. And it doesn't help the person. Importantly, it doesn't help the person themselves understand what their problems are. But it may help you fill out a sheet in your assessment form that is irrelevant for the person that you're actually working with. If they can reach for something, then can they do something with that? Can they pick the cup up? Can they drink with it? Can they pick a tissue out of the tissue box? Can they reach and manipulate a pen, whatever it might be? So if they can transport their hand forwards, can they begin to use their hand in a meaningful way? Or do they have some muscle activity that they can begin to start to explore? So we need to be systematic in terms of how we think about the person who's moving. So shoulder, we're looking at transport versus the hand and the shape that the person can make, pre-shaping and grasp. And if it's something like handwriting, then how do they manipulate that object, or knife and fork, for example, or chopsticks, whatever it might be. And once we've started to analyze where we think the problem is, we can then start to think about what are the other elements that might affect the way somebody's trying to reach. Do they have sufficient range of motion? Do they have any stiffness in their muscles that prevents them from using the muscle activity that they may have, but the stiffness of the joints prevents them from being able to move the range that they need, as one example? Or perhaps it's the coordination of those muscles, that they can extend their wrist and they can abduct their thumb, but they can't extend the wrist and abduct the thumb at the same time. So perhaps it's the coordination of muscle activity that they need to start to think about. And in terms of muscles, if you can start to palpate, for example, for forward flexion when somebody tries to reach, if you can feel the skin lift a little bit under your fingers, then you know that the muscle is working, but perhaps it's not strong enough to actually lift the arm. And I've mentioned coordination as well, that transport and being able to shape the hand at the same time. Now, quite commonly, when people find doing a task difficult, they will use excessive muscle activity. And even in us, when we're learning a new skill, in the absence of brain damage, we all use muscles too much until we become highly skilled. But for stroke survivors, it's doubly difficult because they're trying to turn muscles on as well. And it's not uncommon that people will have what is often described as increased tone or spasticity as another example, which in fact may not be increased tone or spasticity, but in fact that person is trying to use some muscles excessively because they can't turn on the muscles they need. So it's very important when you're first seeking muscle activity and somebody starts to use their muscles too hard, they elevate their shoulder when they try to reach forwards, for example. It's important that they learn to keep their shoulder relaxed as they begin to try and move their arm forwards. And part of our skill set as a coach is to help that person learn when they're doing the right thing versus when they're not doing the right thing, when they're lifting their shoulder versus moving their arm forwards. And it may be that we need to spend a lot of time helping that person in the first few times we see them to learn how to do that and to actually stop the muscles that are working too hard and change their idea of what they're trying to do. So, for example, if somebody on their next attempt, when you say this time when you reach forwards, move your hand towards the cup and allow your shoulder to stay soft. And if they can do it without elevating their shoulder, even if their hand doesn't move forwards, what they've done is changed their motor plan. They've changed what they're doing. So we can start to explore how that person can learn to move well again. So we're now going to apply that information to a man here who's been asked to reach for a glass, and he's been successful. He's reached forwards, he's picked up the glass off the table. But the question for us is it what we would normally expect to see, or does it look different from what we would normally expect? So where do we start? So we have a man who, I suppose my first question to you as an audience, and would be very helpful to get some information from you either in the chat bar or you can shout out to me if you like, is what looks different. First of all, does it look different? Is the first thing. And secondly, if it does look different, what is different about the way he's reaching from what you'd normally expect to see? I'm happy for you to write in the chat, or if you'd like to shout out, that's even better. I could hear a voice or two, it's good. Okay, so elbow's too far away from the body, absolutely. So shoulder abduction, abducting the shoulder. Yes, so his arm is out to the side, much more than you'd expect. The glass isn't very far away from him. There's also a comment about pronation of the forearm. And another comment here that's interesting observation is that the thumb is high on the glass. And Annie mentioned earlier about this very feature of what happens with your hand. If you all now just make the shape when your thumb and your fingers come together, and you'll notice that they all come together around this sort of central point in the middle of your hand, so that when your thumb and your fingers close, they meet around this sort of central point. So if you put a cup in the middle of that, that cup is still, it's just taking up the space in between your thumb and your fingers. But that shape between your thumb and your fingers is still the same as that shape here. That in fact the forces between your fingers and your thumb oppose one another to be able to pick up the cup. So when you pick something up, you'd expect to see the cup, the thumb rather, opposite the middle finger and not opposite the index finger. So in this case, this man's thumb is actually high on the glass and not where you'd expect to see it, where it's opposite the fingers. So we've got an arm that is abducted. We've got a forearm that may or may not be pronated. It's hard to see the wrist, to see what's happening at the wrist, but certainly um, if you can't extend your wrist sufficiently to get the aperture of your hand around the glass, then your fingers are in this position to be able to reach the glass. Then what you'll do is approach the cup from the side, because this is where the aperture is. So what that means is that your shoulder will abduct and internally rotate to be able to get the aperture of your hand around the cup. So we have a man now who has the potential to have problems at multiple places. The obvious place is that his shoulder looks different, but his shoulder may look different because of other things and not necessarily his shoulder. What we're seeing at his shoulder may be a primary cause, or it may be a compensation for what he can't do at his hand. And so we need to start thinking about why he might be reaching this way. So yes, the comments have been that he has problems with his shoulder. His shoulder's abducted and internally rotated. The internal rotation is given away by the elbow crease here, which doesn't face the ceiling but faces towards the wall. His forearm, we come back to the forearm, but it may be that his forearm is stiff and he can't supinate his forearm. He may not have enough wrist extension, and there may be problems with his thumb because his thumb is high on the glass. Now the challenge for us is to find where the problem might be. So is it at his shoulder? Is it at his forearm? Is it at his wrist? Is it at his fingers, at the MCP joints to be able to make that aperture? Or is it at his thumb? And for us to make a sensible decision, we need to be quite systematic. So what are the possible causes and where might we start? So to analyze, we're starting to think, okay, is there potentially a loss of range of motion or stiffness? In which case, in which muscles? Is there a loss of strength? In which muscles? And then is there some excessive force in the way he's actually reaching for the glass, so it doesn't really look like that? Or is there a problem with coordination? And if there is a problem with coordination, then in which muscles and in what's the timing of that coordination problem that we can start to intervene? So this is the critical thing now, is where are we going to start? And it's important because the temptation when we're looking at upper limb function is to go from one thing to another and not be really systematic at each joint. So what I would say is that, to summarize that, is don't be a butterfly. Don't jump from one problem to another to try to find something out, because the person you're working with will also realize that you're not being systematic, and that's not helpful for them. So coming back to this man, we need to start somewhere, and we need to have a rationale for why we're starting where we're starting. So what is our hypothesis as to why he's reaching with his arm in abduction, internal rotation, to be able to pick up that glass? So I'm now going to ask you to vote, because you have to vote. You have to make a decision on where you're going to start and why. So where are you going to start? Are you going to start at the shoulder, the forearm, the wrist, the hand? And what's your rationale? So we've got votes for the shoulder so far. Shoulder, hand. We've got hand positioning, forearm, pre-shaping, shoulder. This drives the hand position. Maybe we can come back to that. Assess the range of movement throughout the upper limb. Okay. I would ask you to be more specific than that and think about which particular joint would you start at? And for what reason? Rather than think about all the joints of the hand, but think about what particular joint do I think may be more involved than the other. So we've got another statement down here about the hand as it drives the shoulder. Okay, so we can see that in the audience there are a number of different kind of ideas around where we might start. So the convention is to start at the shoulder. So let's start at the shoulder. So why might he be reaching in abduction and internal rotation to pick up the glass? What are some of the reasons as to why he might be doing that? If we're thinking about range of motion, for example, how might you test his range of motion? Without putting your hands on him. Because this man can actually move his arm, so we don't need to put our hands on him yet. What would be a way to assess whether he can externally rotate, for example? How might you do that? Change the placement of the cup. Yep, so perhaps move the cup further out to the side, for example, so he has to have more external rotation. I think there's no point in changing the item. That's being a little bit of a butterfly. We need to keep the task the same and analyze this task well before we do other things. If you start reaching for other things, the orientation of those things may be different, and therefore the problem is different. We need to work out why he can't reach. Slide the cup across the table. So the idea there is that you help using the table to decrease the force you need. I would suggest, though, that what we need to find out is he's lifted his arm off the table, so we know he has enough strength to lift his arm up without changing the task, because I think this is one of the things that is very, the temptation is to change the task. Don't change the task. We need to understand why he's having difficulties with this task. So if I, for example, stand here and ask him, so I put a cup in both hands and ask him to externally rotate. And if he has full external rotation, then we've already answered two questions. We've answered the question, does he have enough range of motion? Yes or no. And if the range is the same in both arms, then yes, his range of motion is fine. If, on the other hand, he only got halfway with his left arm and his right arm was fully externally rotated, it would give us both good information. It would give him good information that he can't get his arm there, so this is a problem. But secondly, we can then start to see his control in the range that he has available to him. But let's assume that he does have full external rotation. The next thing to do is to find out, can he forward flex? And we can see that he can forward flex, but can he forward flex without abducting? So give him a target that he reaches for, and perhaps the idea that he's keeping his elbow crease facing the ceiling. And to do that, you can put a dot on the electron, get a piece of micropore or something and put a little dot on the electron. And as you reach forwards, that dot should stay in view. But if, on the other hand, he gets halfway along and then starts to lose that control and loses that dot in vision, then we know that there's some problem with his forward flexion combined with his external rotation. And we can measure the distance he can reach, and that will give us a starting point to then for him to begin to practice in that range where he starts to lose his control. But there's another way of fully testing forward flexion. So if he can reach forwards and the dot stays in view and he can get his arm straight, there's another way that you can test forward flexion and external rotation and supination all together. And that's if you all now just put something on the palm of your hand, keep your hand flat and reach forwards. It can be your phone or a pen or anything, or a cup. And if you can do that and then be able to abduct your arm and then come back to the front, then in fact your shoulder control is probably very good and you don't have a range of motion problem either. So that's a quick test to do for forward flexion and external rotation and elbow extension. So you can check a number of things very, very quickly. And if you know that that's what he can do, then that's not the source of his problem. So what we've done now is we've checked range of motion, strength, and coordination of forward flexion and external rotation. So let's assume that that's okay and that he's been able to do that. Let's go down to his forearm. So he's reaching with his arm in abduction and internal rotation. And if the cup's in the hand and the thumb's a bit high there, so let's do that. In fact, if I take the cup out of my hand and externally rotate my shoulder, then in fact his forearm isn't in pronation, but it's actually probably a little bit in supination, if anything. If not, then it's in mid position. So just to go over that again, his arm is a little bit like this. Take the cup out of the way and I externally rotate. I haven't changed the position of my forearm in terms of its rotation. All I've done is externally rotated my shoulder. And now my forearm is actually in that neutral position. It's not supinated, it's not pronated, it's in mid position. So in fact, this man's forearm, even though it looks as if it's in pronation, it's actually probably in mid position. To test his forearm, just can he supinate while he's holding the cup? Don't change the task. Just ask him to turn the cup over. And if he can do that and he can do it full range the same as the other arm, then you know that his forearm isn't the problem. If we come down to the wrist, here it might be valuable to look at the wrist in isolation. So putting the arm on a table so he can now not worry about his shoulder at all, but we can see whether in fact, while he's holding the glass, can he extend his wrist without the other muscles needing to work. And so what we're really doing now is testing his wrist extension, yes or no. If he can extend his wrist, then we've also checked his range of motion at the same time. If he can't extend his wrist with his arm supported, then we need to perhaps test his wrist extension and see whether in fact there is a problem in terms of stiffness or loss of range of motion in the long finger flexors that are preventing him from extending his wrist, or perhaps a problem of stiffness in his wrist joint itself. So we can test his wrist extension actively in terms of range of motion and strength. And if he's able to do that, we can tick off his range of motion and strength at the same time. In terms of the fingers, you can, if you watch your hands, if you put your wrist in extension and have a look at just extending the MCP joints, but keeping the IP joints a little flexed, you can see that there's a very large range of motion that occurs at the tips of the fingers with MCP extension. So we can now test whether he has enough range in the finger flexors to be able to maintain the wrist extension and extend the MCP joints. If he can't do that, then we may need to test manually whether in fact he does have range, not only in the wrist flexors, but then to maintain wrist extension and then continue with finger extension to see whether in fact he's able to maintain the wrist extension and get finger extension as well. Now, the next part is the interesting one. So people did notice that his thumb was high. And if I have my arm in the same position with my thumb high, And I just don't change anything with my hand, but I just externally rotate at my shoulder. My thumb isn't fully in extension, but it's not in abduction either. It's halfway in between. So with this position here, how do I pick up a cup? I change the position of my shoulder so that now my thumb is opposite my fingers to be able to pick the cup up. So having a thumb that isn't in extension, because if it was in extension, he would reach like that. So he's not that extreme, but he's not abducted either. So what was interesting for me and interesting in my analysis of this man is that I was convinced that his problem was at his shoulder. And I gave him lots of exercises to do for his shoulder, and he came back as an outpatient a week later. Absolutely no difference. He'd done lots of practice, like hundreds of repetitions, no change in his performance at all. He still reached in exactly the same way. And it wasn't until I had a very careful look at his thumb. And in fact, his problem was that he couldn't abduct and rotate his thumb into that inner range to get his thumb opposite his thumb and his fingers. So he compensated for this lack of thumb abduction and conjunct rotation by flexing his wrist a little bit and approaching the cup from the side. So his big problem was being able to have sufficient strength in inner range in his thumb abductors, as well as the coordination between his wrist extension and his thumb abduction. And what we're seeing here with the shoulder abduction and internal rotation is in fact a compensation for what he can't do at his thumb. So this man for me was an absolute light bulb moment that it really made it so important that what you do with your hand will determine what you actually do with your shoulder. So let's just reflect on this for a moment. Are there any questions on this before we start moving on to some video and analysis? So just to reinforce what I've been talking about, give the person something to do. The task needs to be something that the person wants to do, that they want to be able to reach. I'll just go back to that slide. So is it reaching for a cup, or is it manipulating a knife and fork? Start there and then work your way back to work out where the problem might lie. And then from there, you can start thinking about what are the muscles that this person needs to use? What muscles are they using too much? How are they compensating for what they can't do? If they do have sufficient strength, then start to look at their dexterity and coordination. How do they coordinate the action of those muscles if they're strong enough? And always relate it to the skill that they're practicing. And don't go and do something else, because it means that you're not actually listening to the person. When they say, I want to get better at using a knife and fork, then don't go and do something else. Stick with the task and analyze it carefully, because you will find something that is going to be of value for that person to practice. Okay, so we've got okay, there's two questions here that are good questions. So what if there's proprioceptive difficulties on top of this? The critical thing with any function, and I think sometimes certainly sensation with hand use is a really important feature of being able to use your hand well, particularly for fine manipulative skills. But it's not essential. People can use their hands in the absence of sensation. So the critical thing is that you can turn your muscles on. You can actually move your hand. The challenge for that person and for us as clinicians is then to find some way for that person to actually understand how they're using their hand and be much more observant about how they're using their muscles, um, rather than being so preoccupied with that, for example, proprioception. If you find that their proprioception is a problem, the question then for you as a clinician is, what are you going to do about it? How are you actually going to specifically address their problems of proprioception in relation to that particular task? And that's always going to be a challenge. We can kind of seek problems that somebody has, but if there's not something we're going to do about it specifically, then I think we've got to think very carefully about the things that we can give somebody to practice that's going to make their function different, even if they may be lacking in proprioception or sensation or whatever it might be. You will always find a task that that person can begin to practice to change their skill. Okay, the next question here was about, did you find weakness in his shoulder? No, I didn't actually, and that should have told me straight away that I shouldn't have given him shoulder exercises, but I just made that assumption because that's what I'd been taught as an undergraduate, that if you've got problems, if you see problems with somebody reaching, then it's got to be problems at their shoulder. So I just assumed that that was the problem rather than looking at it really carefully. So that was my problem, not his problem. In your initial assessments, do you always test function as opposed to standard strength and range of motion testing? Yes. Always start with the task. Always ask the person what they'd like to get better at and begin at that point and then work my way back to is it then a problem of range of motion and so on? Because what that tells the person is that I'm listening to them, and secondly, that I'm trying to find something that will make a difference to their function, and testing their muscle strength and so on, and range of motion as an arbitrary test of what their arms can do doesn't give them any good information, and it doesn't give me any good information about what they can do. So I'd always start with the task. What if they also have tremors? Oh, goodness. Okay, so there's a whole range of other issues that are going to be problematic for that. We could talk about ataxia and so on. I think if somebody has uncontrollable tremors, then that's a different neurological problem, which sometimes we can address by decreasing the range of the degrees of freedom and getting the person to specifically learn to control one joint at a time and so on. So there's another that opens up another can of worms that perhaps we don't have the time at the moment to address. Okay, would this approach work mainly for people with anti-gravity movement rather than weakness? Yes, I agree that somebody that has absolutely no muscle activity, we need to find muscle activity somewhere. And as Annie was saying, it's not uncommon to find it at the shoulder and to find shoulder protraction. And maybe that's the place to start. But for me, when I first see somebody, even if they've got a dense hemiplegia, I would always start with seeking muscle activity at their hand first, and then work my way back to their shoulder, and then see, in fact, if they can protract. Because you may find that there's a little bit of muscle activity, tiny bit of muscle activity is disguised by a whole range of other aspects to their attempts to move their arm. And so I would still keep this whole framework in mind when I'm looking at somebody that has profound weakness. Because I find that it really helps to structure the way I think and help this person learn where they've got to get to and how hard they may need to work to try to get that to function again. Yes, I certainly the capacity to be able to use your scapula on the chest wall, to be able to protract, to be able to rotate your scapula so that your humeral head stays in the glenoid fossa to be able to reach is an essential part of being able to reach. And I certainly wouldn't ignore it, but I don't go through the whole thing of actually, rotating scapulas on chest walls and so on. But I look at, can the person begin to reach, and what do I see in terms of their reaching? If they need to do specific shoulder rotations, then I'd put that into the task that somebody's trying to learn to do. For example, reaching forwards and looking at the range of motion they can reach forwards before they start to lose the control of their shoulder, and really trying to demand that their scapula does the work that it needs to do. All right. We may move on because I think the questions that you're asking now really relate probably to the next session that we'll have, looking at training strategies, which maybe give you more information then. We now have videos of a stroke survivor, and maybe this will also answer some of your questions about how we might go about assessing somebody who does actually have quite complex problems reaching, and there's problems at the shoulder as well as at the hand. And so where might you start? So in your worksheets, there's a section, and we're really going to be looking primarily at transport and pre-shaping. So this man, Tony, has very kindly offered these videos for us to be able to use and analyze. What we'll do initially is look at the videos. I'll just stop it for the moment and tell you what we're going to do. What I'd like you to think about when he begins to reach, importantly, is what does he have? Because there's a lot of things that he doesn't have. But having a look at his shoulder to begin with in terms of transport, what are the things that he does have when he begins to reach? And then have a think about his transport, and when it starts to fall apart, at what stage does he start to compensate? Because that will give us more information about where the major problems might lie. So we're going to watch him reaching at normal speed, and then I'm going to slow it down. And what I'd like you to do in terms of the chat is write down, first of all, the things that he does have in terms of transport, and then think about the pre-shaping and where we might go in relationship to assessing the problems that he has with his pre-shaping. So let's go with it normal speed. I'm going to slow it down now and go right back to the start. So, as I was saying, what are the things that he does have? He's got shoulder forward flexion, absolutely. What else does he have? We're looking at what he does have, not the things that he doesn't have, the things that he does have. So if we're thinking about his shoulder first, I realize there's a whole bunch of other things. Let's concentrate our attention to his shoulder before we think about other things. At the beginning, does he elevate his shoulder? He certainly does elevate his shoulder at the end, but at the beginning, he's got two things that are essential to be able to reach. What we're seeing when he begins to reach is you're seeing his anterior deltoid here actually turning on, and you can see it lift under his t-shirt. He's got external rotation. Look at that. So when he lifts his arm forwards to begin, you can see his humerus rotate. And if you look where the person has taken his blood, you see that go straight forwards. So it actually turns out to the side, and he begins to forward flex at his shoulder. So he does have forward flexion and external rotation. The question is, are they good enough for what he needs? So that's a different question. But the exciting thing for us as a clinician, and the exciting thing is for Tony, is he does have forward flexion and he does have external rotation. That's exciting because they're essential, and he has them. So that's the first bit of excitement. As he begins to reach forwards, though, what should we expect to see now in terms of his pre-shaping? We should see thumb abduction, absolutely. Anything else? MCP extension? And particularly we should see wrist extension. Now, it's possible that there's a little bit of wrist extension there, or it may be that gravity's pulling him into extension. We're not quite sure. We'll need to assess that. But now, as he gets closer to the cup, so his body is staying very still up to now. He's now starting to get a little bit of elevation. And now he starts to use his trunk and he starts to head sideways. So these compensations with his body and his shoulder are happening at the end, not at the beginning. So he's not elevating his shoulder and he's not doing all of these things at the start. He's doing them at the end. And what that sort of implies is he's using his body to try to make his hand the right shape. He's trying to get his thumb around the cup by using his body to do that. So if we come back and look again from the start, he's reaching straight forwards here. As he gets close to the cup, his thumb should be now abducted and with that size to get around the cup, but it's not. So now he tries to adjust the position of his hand by using his body to get his thumb around the cup, and it doesn't work. It's just completely unsuccessful. So let's have a look at it at real speed again. So the timing of people's compensations also gives us some information about where the problem might lie. So the question now, and I've kind of given the answer away, is if we want to find out more about his shoulder, how might we do that, but take his hand out of take the pre-shaping of his hand out of the problem? So one way of doing that is to keep everything the same, but put a very light object in his hand that requires the same orientation, being upright. And here we have a polystyrene cup, which weighs maybe less than a gram. So it hasn't changed the weight of his arm. And now we can see if there is problems at his shoulder as well as at his hand. So he gets his arm towards the table, but just prior to getting to the table, there's a lot of excessive muscle activity around his shoulder to try and get that last bit of distance. So what this tells us that he does have problems with forward flexion and external rotation, but as his arm gets longer. And as your arm gets, well, his arm, as the length that he's reaching, his arm doesn't get longer, but the distance he needs to reach gets further away. The amount of force he needs to generate in his forward flexors increases because the lever arm is longer across the shoulder joint. So while he can reach at the beginning, as soon as that amount of force he needs to generate increases because he's having further to go, and there's a greater lever arm at his shoulder joint, he needs to generate more force, and he can't do that. So he does have problems at his shoulder. It's not just problems at his hand. And so we would then need to start thinking about how to go about training that. And I think one of the conversations you would have with Tony is around, does he think this is the most important thing to practice, or is there something else that he needs to practice? So what we found out so far, without putting our hands on him, is that he does have external rotation, he does have forward flexion, he does have problems with generating enough force at his shoulder. Where to go to next in terms of our assessment? What are you curious about now? It's a bit hard to de-weight his arm, but we can actually put it in a situation where he needs to generate less force. Wrist extension. Yeah, I think it would be really interesting to start looking at what he can do with his hand, separate from needing to work on his shoulder. So that's what I chose to do, but maybe there's other ways. There's no sort of right or wrong here. But the important thing is to be systematic. So I think the idea that that person talked about de-weighting the arm, here the weight of his arm so the cup is much closer, and the cup is still there on the table. We probably would be better if the cup was weighted a little bit. But we can now start to see that he goes straight for the cup, maintains the external rotation, forward flexion, but he's having great difficulties shaping his hand for the cup. What I think is interesting about this video too is that he gets to the cup quite successfully, and we don't see any compensations at his shoulder. What's he doing with his thumb? We're now actually starting to see some thumb activity that we didn't see before. So what's he doing there? He's extending his thumb. Exactly. His thumb's going up the cup instead of around the cup. So he does have thumb extension, and it looks like he probably has some wrist extension, but we haven't tested that. So he's extending his thumb. It doesn't work. So what does he do with his shoulder? He abducts his shoulder to try to get his thumb around the cup. So now we're starting to see this compensation at the shoulder because of what he can't do with his thumb. So let's have a look at how you might go about testing his wrist extension. So here his forearm is against this cup here, and there's a goal for a cup behind his wrist. So the question here is, does he have wrist extension? Yeah, absolutely. This is, once again, this is very exciting. Let's come back to the start here. So there he is against the cup. and there's his wrist extension. But there's a problem, and the problem is mine in that the goal is too far away. So he can't get that last little bit. So what does he do? He externally rotates his shoulder to get the back of his wrist against the cup. If I'd moved that cup half a centimeter, maybe a centimeter closer to his hand, he would have touched the cup without needing to externally rotate. This is exciting because what we can see, he does have wrist extension, but it's not enough that he needs to be able to coordinate to pick up the cup. Okay, so here's an example of a bad way of testing thumb abduction. And I just included it because I think what we're seeing here is lots of compensations that are often seen when somebody tries to use their thumb and they can't use it well. So come back to that. He's been asked to get his thumbnail to touch the cup. And he has done that. So the goal has been achieved, but he's achieved it by compensating. So how has he got his thumb to the cup? Yeah, so he's pronating his forearm and he's flexing his wrist. So his thumb is extending up and down the cup, and his only way of getting there is by actually moving his hand to actually get his thumb to touch the cup. So it's a problem because he's achieved his goal. So the practice needs to be, or the assessment needs to be set up in a different way. So now he's got a cup against the back of his wrist. He's still trying to get his thumbnail to touch this cup. And the question is, does he have any thumb abduction? So that's thumb extension. He's actually extending his thumb. But if you watch here at that gap between his thumb and his index finger, there's a tiny bit of thumb abduction. And I've taken that little section out to show you that in fact he does have some thumb abduction. You can see the rotation occurring at the CMC joint here, and his thumb is coming out to the side just a little bit. Now that's very easy to miss, and so when we're assessing and analysing somebody's function, it's important, and sometimes videos are a really good way to see. But the other message from me about being systematic is that you need to think about how you structure the problems for the person so you can start to see what muscle activity they do actually have. So he does have thumb abduction, he does have wrist extension, he does have forward flexion and external rotation, but none of them are on their own enough to be able to perform the task that he's trying to achieve. The next question is, what do we give Tony to practice? But perhaps we'll leave that to the next session. So that the purpose of that session was really to show you the importance of being systematic, the importance of taking time at each joint to work your way through, and don't be a butterfly. Are there any questions before we have a bit of a break? All right, as there's no questions, good time to have a reasonably substantial break now. It's 20 minutes. So we'll meet back here at 20 past the hour. So go and have a cup of tea or have a break, a biscuit, something, and we'll see you back here in 20 minutes. Good question. We'll leave that question till later on.
Now, welcome back, everybody. I'm going to get Karl to respond to a couple of the questions. So I'll just turn the recording back on again. Where are we? Here. Oh, recording's on.
Yeah, hello. Again, there's an interesting question that was around. Maybe if I go back to this question as to how, after consistent practice as a therapist, how long do you propose this analysis component takes place? Do you typically assess with video in your first session, go away, analyze it further, and then take your time to do in doing so carefully and return to the patient with a more focused intervention? What I would do in the first time I see somebody, and I suppose if we take two broad categories, somebody that has muscle activity that I can identify and the skill they want to learn, for those people, I would take lots of care about trying to make sure that the practice that they had was ideally going to make a difference to their performance. So I'd spend most of the session, once I'd analysed where I think the problem lies, to actually then set up their practice. And I would probably take most of the session working out an effective intervention that they can go away and practice. And I'd give them one thing to practice, not five or six, but just one thing. And then the first thing I would ask them the next time I saw them is for them to show me their practice. So what that tells them is that the practice is important, but what it tells me is whether what I gave them to practice actually has made a difference. So that then helps me in the next session to say, okay, is it my analysis? If they didn't change, but they've done lots of practice, was it my analysis that wasn't adequate and I need to go back and analyze again? Or do I need to make adjustments to the practice that they're doing so that it does make a difference to their performance? And I'd always come back to the task. So if they're practicing knife and fork, I'd always come back to analysing how they're using a knife and fork after their practice. So it's constantly reinforcing the importance of, has the practice made a difference to their skill? And if they engage with that, then that's the important thing, because they will go away and practice, and they'll practice and practice and practice to change their performance. On the other hand, if it's somebody who has minimal muscle activity, then I will go through that practice and I'd probably start with their hand, because if they're sitting in a supportive wheelchair or whatever it might be, I can support their hand on a cardboard table and examine whether they have any muscle activity. If I find some muscle activity, then that's where I'll begin the practice. But if it gets to the stage where nothing happens and nothing works, then I'd probably go back to protraction and try to set that up. And that may take half an hour to set up that practice. And then once again, that'd be the first thing I'd ask them to show me the next time I see them, to see whether in fact their performance has changed. So that element of analysis, seeing them, setting them up with practice, then reassessing, is the critical thing, whether they've got minimal muscle activity or whether they've got more muscle activity that they can actually use. So hopefully that has kind of answered that question. But I'll hand over to Annie.
Yeah, just to add to that, if I'm taking a video in a first session with somebody, whether it's on my phone or their phone, I would usually show them the video and say, I think from watching this video, the problem's here. And the reason that you're moving like this is because you've got a problem here, here, and here. And so for that reason, I think we need to work on your external rotation and your thumb abduction. Which of those would you like to focus on today? And get them to decide if they want to work on their shoulder or their hand, if there's a problem at both of those areas. So The video would be used in the session, and I would usually watch it with the patient or the participant. And then if it's on my device, I can have a look at it when I'm between sessions and think, maybe there's something else going on here too. So it can be useful for a bit of revision. Okay, so on to the next section, which is where we're going to do analysis of using a knife and fork. And I'm going to be putting you into small groups using the breakout function that we have in Zoom. So this is the form that we used before for picking up a cup, and you have blank ones in the back of your manual, or you can just draw this up on a piece of paper. So you're all going to be looking at picking up a knife and a fork, and you'll be in a group of 3. And I'll just explain what's going to happen there. So you'll need to have a knife and fork of some sort in front of you. So don't run away yet to get it. You'll be looking at transport, the person reaching for the knife and the fork, and also looking at what their hand does. And then at the point where the person picks up the knife and fork, the grasp row there, the 3rd row down, is where you'll be looking at what happens at the point of physical contact with the cutlery. And then the bottom row is the actual the cutting movement. So that's what the video you're going to make will look something like this. You'll have the shoulders and the neck of the person, and you'll have a plate or something in front that you can use for the cutting, and a knife and fork in front. So here's the instructions of what you'll be doing when you go into your groups with another 2 people. One person is going to do the demonstration. So only one of the 3 people will demonstrate cutting, picking up and using a knife and fork. It's better if it's somebody with a laptop, because you can then bring the screen down and they can see you doing the task, like you can see with me here. Whereas if it's a fixed PC or a tablet, it's more difficult to do that. The other 2 people are going to take a slow motion video on their phone or iPad of the person doing the task. And the person who's doing the knife and fork activity, we want the person to start with their hands under the table like this. And you'll be getting practice at the timing of the video. So you'll find that when you use a slow motion video, the very first part of the video is fast, and then it moves into the slow motion. So if you start moving too quickly, you won't get the beginning of your video on slow motion format. So this is all about practicing. And stop when the person's finished doing cutting. If you don't have food, just pretend to cut. That's fine. The person who's doing the demonstration just needs a plate, a knife, and a fork. Play around with the lighting. It's not good to have a window behind you in the daytime, because that will make it difficult to see. So spend some time looking at your environment while you're making the video. That's what it should look like, and your video will, as I said, move into slow motion. So I'm going to stop at that point. Hopefully that makes sense. You have the instruction in your notes in your manual. For this, we'll spend, let me just see what my timetable is, how long. We usually do this for about 30 minutes. So we'll see how long you need. We'll be coming around to give you a hand with that. How are you going to share the video? Once you've made the video, 2 of you will be making a video. If you want to share it with the person who's demonstrating, you can send it via WhatsApp. Or if the worst case scenario, you can actually just bring your telephone and show it on the screen like that. But usually people can send the little video via WhatsApp if people have that on their phone. So hopefully between 3 of you that will work. Karl's going to open the breakout rooms now, and we'll see you back here in the big room in about 20 minutes to half an hour. Okay, so some of you would have provided more detail in your analysis and in your notes than others, but hopefully this will help you to get the level of detail that you need for this kind of analysis. So this is a slow motion video that you can see of Karl. Some of your videos may have been different depending on the kind of table you had. And most of you wouldn't have had actually food to look at. So I'm going to take you right to the beginning of the video here. And we'll look at the first part, the transport. And hopefully you also got used to using the slider at the bottom of your video like this. I can get everybody to go on mute. Thank you. Karl, if you could check if there's anybody who needs to be put on mute. So you can see, as Karl described earlier, there's shoulder forward flexion. The arms are coming directly forwards. There's a little bit of extension, first of all, because of the table being very close. Shoulder extension, first of all. Elbow flexion. A little bit of abduction, but not a lot. And then the humerus, both the humeruses come forwards. And we're looking mainly at the knife here. We also can see some external rotation. So at the moment, the right arm is in internal rotation and it's moving now to external rotation at this point here. And the elbow crease starts to move upwards towards the ceiling. There'll be a bit of protraction at this point as well because of the distance, protraction of the scapula. And, you know, you could argue, yeah, there's a little bit of elevation because of the height of the table, but the main things are there's some extension, some elbow flexion, forward flexion at the shoulder, and external rotation. At the pre-shaping, if we look right from the beginning here, the hand begins to open. So the MCP joints open a little bit more, and the thumb starts to abduct and oppose. The wrist's in flexion down towards the knife, and you can also see some radial deviation there. Ulnar deviation, sorry. Okay, so that's the first two rows of your worksheet. When you get to the point of picking up the knife, hopefully some of you picked up some of these features. So the thumb and index finger close in together, and some of you may have had the knife being moved into the upright position like this, and the index finger is mostly doing the pushing to get it to the upright position there. The thumb is holding it fixed, and the thumb is flexed and in a rotated opposed position. The index finger is flexed at the IP joints and at the MCP joint, and the index finger is also rotated around into conjunct rotation. So the tip of the index finger is sliding underneath the knife. And they lift up. And that's what's often really hard for stroke survivors. They just cannot maintain that opposing forces of the thumb and the index finger. Now I'm going to move straight to this point here. And hopefully most of you had a good view. So most of the fingers are flexed around the handle of the knife, so inner range flexion. So that means that the fingers around the handle of the knife are all flexed. Flexed around the handle. The index finger is the one exception. So the index finger is extended at the IP joints, flexed at the MCP joints. And you can't really see the thumb very well, but it's adducting and holding the knife in this position and flexed. So if we think about that in a written description, we've got the transport components, the what we can see the thumb and fingers doing. and the forearm. At the point of grasp, when it's been picked up from the table. Now, I haven't talked about eccentric or concentric muscle contractions very much up to this point, but you would have picked it up, I think, in the pre-reading. So we can see the wrist is flexed to reach for the knife. Gravity is pulling the wrist into flexion. So the wrist extensors have to, if we want to move the hand into an appropriate position for picking up the knife, then the wrist extensors have to contract eccentrically. They have to shorten in that lengthened position. If we look at knives and forks, we'll see some people do hold them in different ways to what I've just described. So here we've got a friend of ours who does hold their knife and fork in a different way, which is quite common in North America. So were there any differences in any of your groups? You can write this in the chat or you can unmute. Any differences in the way that your person either picked up or used the fork for cutting? It is quite a challenging task to analyze, and once you've done it a few times, you get more and more familiar with what's involved. We are going to spend time in the third week looking at training knife and fork, so we'll come back to this. Okay, I don't see any questions, so we're going to have a look now at a survivor doing the same task. This is a video of a man who I worked with a few years ago, and the Australian Stroke Foundation made a series of videos and learning modules for therapists, and this was part of the learning module on training upper limb function. So if you wanted to access the full 45 minutes of the video and the learning module, it's free, and it's on the Australian Stroke Foundation's Inform Me website. So it's the Australian Stroke Foundation, and they have a separate web page for health professionals called Inform Me, and you can look for the different learning modules. There's also a worksheet that I want you to fill in on your own. These are available at the back of your notes, but you can also just draw this up. So what you're going to do when you watch this man picking up the cutlery is to think about what looks different. That's the first column on the left. Is there any essential component like forward flexion missing? Do you think he has problems with external rotation, yes or no? What about the opposing forces? What about being able to make the appropriate shape when he's reaching for the fork? And then at the point where he physically makes contact with the fork, can he get the forces to be maintained to pick up the fork? So you're looking there for any missing components and any compensations that you're seeing. So compensations like shoulder abduction, for example. And when I write this down, I tend to keep my essential components together, and then I keep my compensations together in a little group. The second column is the potential impairment. So which muscles do you think are weak? Because then you're going to have to target them with training and refer to your muscle list if you need to. Testing strategies, what would you do to determine if you think there's a problem at the shoulder? And stay with the knife and the fork. What would you ask him to do to try and work out if there's a problem at the shoulder, yes or no, or if there's a problem at the hand? And then what might you do for training? See if you have some ideas for training and for measurement. So that's your job, to fill in the worksheet as you watch this video, which is going to be on a loop. I think you can pick that up with your left hand. Yeah, You can pick. So I'll turn off the audio because it's a bit annoying. And you can see it lands on the floor. He's not successful. So start with the left-hand column of your worksheet. I'm just going to turn the recording off because I'm going to give you a little bit of time to do this. You'll probably need about 10 minutes. Put the recording back on again. So this man is clearly having difficulty with picking up the fork, as you can see here. He's not successful with the goal that I've given him. He can transport his arm, so he can get it up from his lap and can reach forwards. And he can make an opening, but it doesn't look quite right. So in the chat, what I'll ask you to do is make a decision about where you think you would focus on for what would you ask him to do next in order to give you more information, rather than getting him to do this repeatedly. What might you ask him to do that would give you more information? So we've got one person saying assess external rotation, somebody else saying practice external rotation with an object in his hand. Somebody else wanting to look at wrist extension, put the fork on his lap and see whether he can forward flex his shoulder. So yeah, you could certainly, if you're trying to stay with the fork, can he actually hold on to the fork and could he slide the fork and his hand forwards on his lap or on the table? He's probably able to do that on the table. To test external rotation, how might you do that with the fork? You might be able to ask him to see if he can take the fork out to here. He can probably hold the fork. Can he take the fork from here to here? Or can he only do it with an abducted arm? So that would be one way of testing external rotation. And forward flexion, we might see if he can slide it forwards without his arm having to come out to the side. And I think from memory, this man did have some forward flexion, so he may have been able to go forwards a little way, but didn't have a lot of external rotation. Let's have a look at what other people have suggested. So we're wanting to find out more about his ability to pick up the fork as well. So that's giving us information about his shoulder. If we want to find out more about his hand, you might notice that his thumb and his fingers are not opposing well, which I mentioned before is essential. You've got to be able to oppose the forces. So we could see if he can actually get his thumb and his fingers to touch together. This man could do this. He could flex his fingers, but he couldn't actually bring them into this kind of rounded cupping position. And you can see he's got quite a flat hand. Although he can bring his fingers in around, he's not able to get them around the handle of the fork very well. He's really only getting two of his fingers around the handle of the fork. The other fingers aren't participating very much at all. So if we want to, we can find out, can he actually get the index finger and the thumb to oppose? Yes or no? Can he get the three fingers to oppose? Yes or no? And if not, that might be part of the practice task that we're going to focus on, is to see whether he can actually, perhaps with a fork on the table, can he start to get the fingers on either side of the fork accurately instead of doing this? So that might be part of his practice. Grip strength, his problem isn't strength. He's actually quite strong. You can see he's putting a lot of force there. So he doesn't have a strength problem. He's got a coordination problem when it comes to the opposition. Somebody else is suggesting trying an adapted fork. Can he actually use a slightly bigger handle and pick it up? And he may be able to if it's a bigger fork, but can't do it with a smaller fork. And often with a very big handle, you can pick it up in a different way with a different strategy, but he needs to be able to learn how to oppose the thumb and the index finger. So if we go to the next slide, you'll see on the worksheet that's filled in at your note on your notes, he's got a lot of extra shoulder abduction. He's also using his finger flexors and he's flexing his thumb quite a bit. So that means that he's got problems with bringing his arm forward with external rotation, which many of you picked up. He's having difficulty getting his index finger and his thumb to come into this rounded, cupped position. Also, when he was opening his hand, he didn't make a very big opening for the thumb, and he tried to compensate by using a bigger space with his fingers. So he's got problems with that rotation for index finger and thumb. What could you do? See if he can get his tips of his finger and thumb to come together. Sometimes putting a dot on each and getting them to oppose can be something he can do, just sitting and practice that without any special equipment. And we looked at checking his external rotation and can he slide the cup or can he slide the fork forwards. How would we get him better at being able to do this, to be able to get the thumb and index fingers together? Sometimes we use electrical stim on the thumb and on the hyperthinner ends to get the fingers to come together, getting him to match two dots together, giving him goals, perhaps getting him to lift a block where he's got to get his fingers on either side, and also, as I said before, lifting the handle of the fork and getting the thumb and index finger on either side and not doing this. So you'll see some more videos of that in the third week. And there's some examples of measures that you could take. So in summary, if we're thinking about analyzing and identifying where the problems are when somebody's trying to pick up forks or knives, where you put the knife and the fork on the table will influence how people pick them up. So if you have the knife with the blade facing away or the blade facing in will affect how people pick it up. And obviously how far away it is from them. People need accurate forces. The thumb and the index finger and the middle finger need to oppose accurately. Otherwise, what you just saw in that video will happen. And to be able to hold the handle of a knife and a fork, you need this inner range, really closed flexion of the ring and finger, little finger in particular. Otherwise, it gets loose and the person doesn't have a stable knife and fork and a well-grasped knife and fork to cut with. So that's really essential for holding the handle of the knife and fork for cutting. Are there any questions or points of clarification at that point? Because we're coming to the end of the workshop, as you've probably seen. If you go back over the book chapter, you'll also get a few more tips about analyzing and training cutlery. But we do spend quite a lot of time on that in week 3. So key take-home messages. Be systematic and goal-focused. Ask the person to reach for something or to move an object and avoid manual guidance whenever possible. So if you're a hands-on person, try and sit on your hands and think about how often you may put your hands onto somebody, which interferes with their motor plan. If somebody's going to learn how to be able to do this, they have to actively engage with the planning and the doing. Use slow motion video, and that's going to be part of your homework between now and next time we meet. Start to recognize and know what you should expect to see when somebody's reaching and preparing to open their hand and grasp. The hand is really what's important. That man in the video was trying to get his hand to pick up the fork, and that was the reason why he was transporting his hand forwards. So the hand is driving the shoulder. Start to look for cues when you're watching people and watching the videos, such as the change in the elbow crease for external rotation, the thumbnail turning around for opposition, and the accuracy of the thumb opposing the index finger and the middle finger. Think about testing your movement hypothesis where you think the problems are, and start describing the movement problems when you're in team meetings and in your medical records at a level you can intervene. So where is there a weakness, which muscles are the problem, and how are you going to train them? When we come back in a couple of weeks, we're going to be looking at training people who are very weak, starting at the shoulder and then moving down to the hand, and giving you examples of how you would use these different treatments for or different interventions. And then we'll come back to training cutlery in week 3. I'm going to finish with the quiz questions. Karl's just pointing out a question. I'll get you to do the quiz questions first, and I'll have a look at the chat. So missing essential components that you might see when somebody's reaching for a cup. You can see them listed there. Thumb abduction is important because it enables you to make a space, even a small space, for something like a fork or a knife. When you're using a knife or a fork to cut, these are the components that you need and that you identified when you were watching the video of each other. At the shoulder, common compensations, like you just saw in that man's video, shoulder abduction, internal rotation, and elevation. If you can't get your thumb to abduct, then you might pronate your wrist, your forearm, abduct your shoulder, and internally rotate. Commonly, if somebody's got problems with a fork, they've got problems with that rotation and the inner range flexion to hold the handle. What might you do to distinguish between problems at the shoulder and the hand? Get somebody to hold a cup, for example, and see if they can slide it along their leg or along the table straight forwards without it going off to the side. So you're helping to reduce the amount of weight of the arm by supporting it on the table. Now, a question there, you would train thumb opposition using the second and third fingers. If somebody has problems with opposing forces, then what they need to learn to do is get the thumb and index finger to oppose. But if these muscles are weak, the palmar interossei are weak, then we need to find some task-specific training strategies that will help those muscles to start turning on. So we need to try and get a message from the brain down to these little muscles so that the index finger can start to turn around and do that. And one way of doing that is to have, you can either have a block, a wooden block, like that, where the person's got to try and get their index, the pad of their index finger and the pad of their thumb on either side to be able to pick up the block like that. So it's not on the side. It must be the pad of the index finger. And see if they can then put a bit of pressure on there and lift it up and put it down. Lift it up and put it down and not turn to that position. So that's going to require quite a bit of thinking. And then you might move on to, you might have the knife on the table and they're trying to do the same by lifting up the handle of the knife, not doing this, but accurately doing this. So that would be training thumb and index finger opposition. These fingers wouldn't be doing this. And then Ruth's asking, would you say increased tone was a problem for this man? No, that's a very good question though, Ruth. I would describe that man as using too much flexion And he's trying to use the long finger flexors to be able to pick up the fork, because the palmar interossea aren't able to make this position and this opposing position here. So he's using too much muscle activity here. He's also using lots of muscle activity here when he's pre-shaping, because he's weak in other muscles. So it's very common that you see that kind of strategy. Homework tasks. This is possibly, I can't remember whether this is in your manual or not. If it's not, you can take a screenshot, and I will send you an email reminding you what to do. So you want to make a video, a slow motion video of a patient ideally that you're working with to analyze. If you don't have somebody with a stroke or brain injury that you can do this with, maybe one of your colleagues will have somebody that you could work with. And that would be better than, using a family member. And also the second task is record how many repetitions a person completes in your therapy sessions. So if you're working with somebody in rehab, keep a record of how many repetitions they do. And you may want to use a tally counter, this is a tally counter for anybody who doesn't know them. Or you can just count them on a bit of paper. And we'll be asking you to report on the number of repetitions when you come back to the session in a couple of weeks. Justine's asking, is somebody with a spinal injury appropriate for the video? Yes, you can certainly use them, and counting repetitions would be very relevant for anybody that you're seeing and doing practice and rehab. If somebody's got a permanent weakness in the muscles, then you're not going to be seeing any change, but you can still do the analysis. If somebody's got an incomplete spinal injury, that would be probably better. But yeah, if that's who you're working with, then that's fine. Just a reminder that there are other workshops that some of you may be interested in on the Stroke Aid website, and you'll see them on the homepage. We also have a whole series of lectures that you can dip into under the resources tab on the homepage. They're about an hour each, and they're free, so you can use them at staff meetings. So we've got ones about muscle overactivity, so that goes to that question that somebody asked just now. How do you determine between muscle overactivity and tone? So Karl talks a bit about that in that lecture. Okay, I'm just going to stop there and see if there are any questions before we finish up. We'll be meeting again in 2 weeks' time, same time. So that gives you lots of opportunity to practice some of what you've been seeing on the screen. Anybody has to go? That's fine.
Thank you.
Pleasure.
So we'll
Thank
wait
you.
around,
Thank
we'll
you.
wait around for a little while in case anybody has any questions before we go.